Welcome to the Redhead Reveal podcast. I am Jenn Pinkerton, your Redhead host, a psychotherapist, high-performance coach, writer, and speaker. As a connection expert, I help people reveal their connectedness within relationships, transforming from the root causes of beliefs and behaviors that hold them back from thriving in life. Let's talk about how you're thriving. Today, we're going to talk about painful sex. Have you ever had questions about your pelvic floor? Do you want to know more about vaginal health? Do you want to have a sex life where you're thriving? It's a pretty interesting conversation. Stay tuned. All right, I'm excited today to welcome Dr. Sonia Bahlani, pelvic pain specialist, author of Dr. Sonia's Guide to Navigating Pelvic Pain, Result-Oriented Strategies for a Better Quality of Life. I know you're in NYC. Welcome here to the podcast.
Thank you so much. Thank you for having me. I'm excited to be here.
You know, this is a topic I have been wanting to cover. I do a lot of sex therapy in my practice. I'm a psychotherapist. And we also talk about a lot of different women's issues on this podcast in general as well. And, you know, sex and pain have become something that a lot of women, I think that is a synonymous, you know, those two words. And those two words do not have to be juxtaposed together. And so I really can't wait to have you really dispel some myths about that and talk about pelvic pain and sex and women and what that looks like. So I'm just going to dive right in with you on that.
I love that. And I have to say, I really love and appreciate that you use your platform to talk about topics like this, because what I find is that oftentimes what I do is so stigmatized and normalized only because we don't want to talk about it that no one wants to talk about it. So I love the opportunity to kind of shed light on this stuff.
Well, and some of it might be personal. I do a lot of personal information on this. You know, I'm about to be 53 years old. And so when you're in that menopausal age, women have a very different experience with sex than men. And from a sex therapy standpoint, that's something that as a clinician, we have to be very cognizant and aware of. But I agree with you that there just isn't a lot of information or maybe attitude, I should say, not information, but an attitude present that, hey, this is normal. This is normal. And there's a way to address it. There is a solution. You do not have to grin and bear it. And sex is supposed to be pleasurable and wonderful, you know?
Yep, absolutely.
So how did you get your start? Let's back up a little bit. You know, how did you get to where you are? Because you are such a specialist in this field and in this place. And I'd love to know kind of how you got there and what propelled you to do this.
Yeah. You know, I went into medicine not really knowing what I wanted to do, but knowing that I loved women's health issues. So I was doing my residency actually at Cornell in New York City. And I was finding that in my clinics, I would meet a lot of people who would report vaginal symptoms, GYN, women's health symptoms, in correlation with urological symptoms, but like frequency, urgency, incontinence. And these women were often shuffled from doctor to doctor, and they were often like, I don't have one place that I can go to where I feel like someone's looking at me as a whole. Like I feel like I'm just like compartments, you know? And so that's kind of what propelled me to pursue a fellowship in the Department of Urology, which for anyone in medicine knows is very like non-traditional. And then I went on and I worked in urology and academics for almost 8 years. And then, you know, I went out and started my private practice because I felt like I wanted to do things in a certain way to be able to take care of a patient as a whole. And that's really my philosophy of care, is to be able to take care of all women's health issues, just not some of them.
Okay. And you had the background then in, is it OB-GYN and urology, right?
Correct. Yeah.
Which is kind of rare, right? I understand that's not really normal.
Yeah, no, it's not really normal. Like a lot of people will do urology and then do like a fellowship in women's health stuff, or they'll do women's health and do a fellowship in urology, but it's often the same department. What's different is that this was in two different departments, so very non-traditional.
But I love people that buck the system a little bit. I love people that I look at people like you who say, you know what, this is a need. I'm doing it this way because I can serve more people. And that the altruistic, you know, idea of that really speaks to me.
Oh, thank you. And I love it. It's a niche, but it's so needed. And I really, truly like love what I do. I feel passionately about it.
And I know that by some of the things and quotes that I've seen you say and hear you say, because you talked about like going to medical school and not learning how to properly evaluate the pelvic floor. It's like going to culinary school and not learning how to properly prepare chicken. I love that. I was like, this is great.
Because, you know, so many well-intentioned OBGYNs will see patients and they will evaluate the uterus, they'll evaluate, but they will never take a feel of the pelvic floor. So people can be in pain for all these periods of time and they don't know why. And no one's ever told them, hey, you have something called pelvic floor dysfunction. Your pelvic floor is actually overly tight. And one of the biggest misconceptions is that a tight pelvic floor is strong, but you think of it like a bicep, it's very weak. And so there's just all these misconceptions out there related to pelvic floor.
And I think a lot of times I see that women, if someone comes to me for sex therapy and they talk about sex being painful, I, as a clinician, of course, refer them to a medical doctor to make certain that we're not dealing with something, that is medical versus mental, or is it a combination of both? And that's part of me doing a well-rounded job. However, oftentimes I will refer someone to go see their doctor. They will come back from seeing their doctor and they'll say nothing's wrong with me. But as I do further evaluation and further intake with this client, I realize no, there's most certainly something medical here that I can help you with how you think about it. I can help you with the limiting beliefs of that. I can help you with the anxiety about it. I can help you with what's happening in your brain, neuroscience aspect of what you're feeling when presenting with sex, but I cannot help you with this part. You've got to go see a pelvic floor specialist. And I see that often, but I witness that disconnect so frequently in my practice.
And I so appreciate you saying that because it's true. I mean, 9 out of 10 people who come into my office, their issue, even if it's painful sex or whatever, is not unilateral. Like it's not coming from a single source. So oftentimes I'm working with people like you, like sex therapists on that angle. And then we're doing stuff physiologically because if we don't combine those therapies together, then there's no true full relief. Because like I always say in my practice, the absence of pain is not pleasure. So like just because I can get you out of pain, our job hasn't finished there. You know what I mean? Like sex should be pleasurable.
Yes, agreed completely. And I mean, sexual health is health. That's something I say. And then I saw that that's something you kind of talk about too. Because if
Yes.
we're not having a healthy sex life, we are not thriving in our relationship. There are couples, of course, that can make a decision that that's not the type of relationship they have, and that's their choice. But if your choice is to have a relationship that has sexuality, passion, and intimacy in that way, physically, then you've got to have a healthy sex base to work with. And if you're suffering with that, it doesn't feel pleasurable anymore, then there leads in that whole aspect of shame. I feel ashamed that I don't want to have sex with my partner.
Uh,
And it becomes a whole nother issue.
but the stigmatization of sexual disorders is just so prevalent, any way we slice it, whether that's from a psychological perspective or really from like a physiologic perspective, which is what I deal with a lot because there are patients that will come into my office and sexual health is health, but sexual health is a marker of the way your cardiovascular system is working, the way your neuromuscular system is working. So when you're having issues in that area, it's often like a later sign of other things happening physiologically to begin with. And yet it's one of the things that people will come in with and be like, but it always hurts, right? It's supposed to hurt for everyone. Or, I just figured when I hit menopause, that was just the new norm. Like because of all of these shame issues surrounding sex.
Absolutely. And something that I hear a lot of women talk about is, I cannot have any lubrication with my body anymore because of where I am in menopause. And I'm just accepting that. I'm like, whoa, whoa, we don't have to accept that. We do not have to accept that has happened. Sure, that may have happened to you physiologically, but it does not stop there.
No,
There's a lot of different approaches to address that. And I think that's so important to give a sense of that is not okay to just
no.
accept that.
Right. And conversely, I have a lot of younger women who are like, I don't want to use lubricant. And I'm like, but why? Everyone should use lubricant. Do you know what I mean? And there's much more we can do for postmenopausal dryness than just lubricant. But my point is like it goes both ways on both. You see it on both ends of the spectrum.
Right. And I don't like to plug any particular approach that I, have not ever used myself or that I have clients that have used. But I mean, there are lubricants that are also done on a weekly basis. There are things that you can do that are not have to be in the act, because I find that sometimes women do feel a sense of embarrassment and that there's something wrong with me. Hold on, please. I've got to reach in my nightstand and get this before we continue to have sex. And there's a sense of the moment's lost. Now, truly, I believe that you should not be having sex if you can't talk about sex. And if you can't tell your partner, hey, I'm not wet enough to have, sex right now. I've got to have some lubrication. If you can't do that, then we've got a much bigger problem than that. But
Yeah.
that being said, I do think there's a lot of different products out there that you can use not only in the moment, but also things that are more proactive based, where you can do on a weekly basis or ahead of time. And I think those are worth mentioning that that does exist. And they can go
Right.
see someone like yourself to really tell them there's more options than just that, or maybe in addition to that.
Agreed. Yeah. And you guys can't see me, maybe you can, but I was like golf clapping
Yes.
because that's so true.
Mhm.
Um, and there's more we can do than just lubricant, right? Like, so even then, but that's just one form of even like very easy over the counter things we can do, but 100%. And I think that sometimes we also kind of normalize these life changes as signs of like, well, then maybe we just shouldn't be having sex. But that's not true either. Do you know what I mean? Like these are
Yes,
normal
sure.
changes, but we can alter things and there is no shame in this game. And like, so yeah.
Well, and to me, that would be some equivalent of saying, oh, maybe I'm a little bit older and I don't have the stamina I used to, so we're just going to stop having sex. You don't have the same stamina because maybe you're not in your 20s anymore. That's ridiculous too. Like we can evolve in some ways, but not others, because the others have shame associated with them and stigma
Right.
associated with them. And I think women specifically start to feel as though they are less than. And it's an age thing. It's a I'm trying to chase my youth, and it becomes a whole another mental aspect of it. And that's why I think it's so important for people who are having trouble with sex to work on both sides, to see someone like
Yeah.
yourself and then also work with a sex therapist to address how to make sex more enjoyable.
I almost always agree with that philosophy. I ask my patients to see a sex therapist at the same time as me because I find that the collaborative treatment and partnership together is really, really what catapults them into true like enjoyment of sex and really having a good sex life.
Absolutely. So, in your book, Dr. Sonia's Guide to Navigating Pelvic Pain, you talk about all these result oriented strategies. I want you to give a little bit of information like what was your motivation for writing this book? How did you get there to know how necessary this was?
When I was in academics, so I like a little bit about me. I was in academics for almost 8 years of my now 12-year career.
Mhm.
And um, in academics, academic big corporate medicine, they ask you to see, X amount of patients a day, which is incredibly too many patients a day. You're not able to really
Right.
sit down with them.
Right.
And so when I left my career in academics and went into private practice, I realized that one thing that I was foregoing was access to care to all. Because when you're in private practice and private pay, there's oftentimes barriers to care. And that occurs throughout our field because insurance doesn't often recognize what we do as actual entities for care. Like if I say a patient needs something like a Valium suppository, insurance will say, no, pelvic floor dysfunction is not a thing. Here's oxycodone. And so, like, you live in this world where you're trying to navigate this. So, one of the points of the book is to be able to empower patients to have full access to the remedies that we have currently and be able to discuss that with their doctors wherever they are, because some don't have the luxury of seeing subspecialists, but still able to kind of help them help themselves.
Mhm. Exactly. And I think that having a book to educate people, to let them know, number one, normalizing this and to give them some true strategies about what you can do. So can
Yeah.
you highlight just a few things for our viewers and listeners that, you see that is recommended pretty often in your book that are, more surface level, because I know everybody's individually different about what their presenting concern is, but to give people some overview of, hey, here's some things that we do, in
Yeah.
working with pelvic floor dysfunction.
So, there are so many different ways to approach this. So some of my patients come to me and they say, I really am not interested in medication. Like I know what's happening with me, but like to me, medical therapy feels like far down the list of things I want to do. So one of the most basic things that we can start with that actually has really good data and provides really good effective care is things like pelvic floor physical therapy. It's something that you can find throughout the US and really throughout the world, and now there's more of a push for it. And it's really understanding your pelvic floor, understanding how to Kegel. Do you really need to Kegel? Do you know what I mean? I always Kegels have the best PR, but that's because many people don't need to be Kegeling in order to have a good sex life or to have a good, healthy pelvic floor. So a pelvic floor PT can really evaluate what your pelvic floor is like in that point, and then give you good stretching exercises, sometimes myofascial release, which is where they release the muscles at the same time, and actually give you a program that's designed for you. I'm a huge advocate of individualized care. And so, there's no one stretch I would recommend, like the pigeon pose or something
Right.
like
Yes.
that. Other things that I think are super important are really maintaining good, healthy habits for your pelvic floor. So number one, constipation. Constipation is one of the things that I see in women, men, but really in women with pelvic floor dysfunction almost 80% of the time, right? So if we're not having proper bowel movements throughout our day, what's going to happen to the pelvic floor? It's going to contract, it's going to tighten. And then guess what's going to happen if that becomes your new steady state? You are going to develop signs of pelvic floor dysfunction. Or it's vice versa. What came first, the chicken or the egg? So control.
Can I ask you right here, because I think that's so big and I really want to stop and point this out. What I hear you saying is that if you're a woman who suffers from repetitive or consistent constipation, that absolutely can correlate to having problems with your pelvic floor, which in turn has problems with having sex in a pleasurable way.
Yes.
I mean, that is a
100%.
really big thing to think about. And I'm not sure that most people have that correlation at all.
Yes. And we'll take that one step further. It can even be indicative in patterns of sex. So, so it's kind of vice versa. What came first, the chicken or the egg? Did your constipation cause pelvic floor dysfunction, or did you always have a tightened pelvic floor, which led to chronic constipation? We don't know. Okay. But with that, certain patients will notice that, you know what, maybe I can have sex missionary and I'm okay. But when I try doggy style or reverse cowgirl or whatever other position that's more posterior in nature, I can't do it. I'm in a lot of pain. And there is a reason for that that's associated with the pelvic floor that we often see correlated with bowel habits. That's a contraction of the puborectalis muscle. So for sure, we see that all connected together.
And as you say that, it makes a lot of sense when we're thinking about anatomy. But I think before you said that, I don't know if a lot of people would make that connection.
Yeah. Yeah. So constipation is another big one. Another big one I always say is not sitting for long periods of time. So there was like a New York Times article on how pelvic floor dysfunction has become a problem after the pandemic. It's a disease of the pandemic because we all tended to sit for long periods of time on our meetings. And
Gosh,
so
I have never heard of that, but that really makes a lot of sense once again when you think about the anatomy and how that works. I mean, we're not designed to actually sit all day. That's not the way our bodies work.
exactly. So things like, getting a standing desk, making sure you're taking breaks throughout the day where you're actually walking around, not holding your urine in. All of these things are just healthy lifestyle modifications to ensure that your pelvic floor remains healthy because it's like muscles anywhere else in your body. Like me being a physician and a surgeon, I tend to go like this because I'll operate a lot throughout the day. So I get trigger points in my neck. It's the same thing like getting trigger points in your pelvic floor. People just don't realize it.
Mm-hmm. It makes so much sense. And I think also people don't recognize the correlation between some of these things until maybe something happens like, oh, when I sneeze, I'm going to have to immediately run to the bathroom. And
Right.
I think that sometimes is only then is that the sign of we've got a problem versus some of these other things that maybe just go a little bit under the radar, and
More
people don't
nuance.
recognize that.
Yes, yes. And I'm all about the nuances because if we can, modern medicine is great at fixing things. We are not good at preventing things. But if we can prevent things from occurring, then you're in a lot better position.
Absolutely. And I really like that approach. So you've also talked about how sex and pain, if you really are having pain during intercourse, that's a vital sign. Like that is right away, we need to be looking at this.
Yes, absolutely. Because some people, so whenever someone comes into my office, what I'm trying to do is understand where their pain is coming from. So I'm asking a lot of questions. Our appointments are an hour long. And one of the first questions I ask is, did you ever have trouble placing a tampon? And many patients will say, now that you mention, and they might be coming in for painful sex at the age of 30 or 40 or 20 or 50. And they say, you know what, now that you mention it, I never wore tampons because, my mom tried to teach me, but it was just too painful and I never wanted to do it. So, what I'm trying to do is this primary or secondary? So wait, there have been issues potentially prior to even the first time you had intercourse, Or is this more secondary? Were you able to have pain-free, pleasurable intercourse and then something shifted and now you're not? Because you're going to treat all these entities so differently.
Mm-hmm. Yeah, and I think that it's the nuances you're talking about having a clinician such as yourself, a doctor such as yourself, who can go a little deeper to really evaluate some of that. And that's why I'm just, again, I've got to say it again. I really always say you cannot, you can't just go to a doctor and accept that there's nothing wrong with you without seeing a pelvic floor specialist. You got to go someone that understands pelvic pain.
And to that point, like I love that you like understand and you work with this stuff. Oftentimes, while well-meaning doctors are amazing and great, if they don't have the education or the background, and unintentionally, they're gaslighting patients into believing that there's nothing wrong, right? So like, oh, well, there's nothing wrong. Have a glass of wine before sex, or like just breathe and relax. And these things are actually stigmatizing this further and almost making it feel like sex should be painful, which it shouldn't. Having a glass of wine before sex is not going to cure whatever root cause is actually causing this dysfunction.
Right, because then now we've got this narrative, this story in your head. Now there's something wrong with me. I just have anxiety around sex. What is wrong with me? And then there's worries, is my partner not going to stay with me because of that? The limiting beliefs that I feel like it's this spiraling that can occur from, yes, what might be well-meaning, doctors, but it's missing the mark completely. And I really try to encourage women to avoid that entire conversation. If you go to your medical practitioner, whoever it is, and they're not recognizing or acknowledging that what you're saying is legitimate, and you
Yeah.
feel as though they're dismissing it, you immediately need to go see someone else. It's
Yeah.
just that simple.
Yeah. Or how many times I have partners come in with their patients, and because my patient's been told for the last 7 years that her pain is just non-existent because she looks fine on the outside, and then the partner comes with her and says, oh wait, so there's something actually there that you have to treat. And I'm like, yes. And it's almost like because they've been on this journey together, it's like painful for the patient and the partner alike. So
And how often do you see women who have had children versus women that haven't? I get asked kind of that question often about pelvic pain and pelvic floor dysfunction, the difference between after childbearing and or before childbearing. What can you tell us about that?
so I think that one of the biggest misconceptions is that pregnancy and vaginal delivery will cure you of your pelvic floor dysfunction. And it's definitely something that's out there that people have, and it's actually, there's data on it, and it's really metza, not great data, to be honest, which is why I say. And so, a lot of people will come into my office and they'll say, as long as I can get pregnant, because some people can't even have penetration, right? So I'm treating people who can't even have penetrative intercourse. Like as long as I can start to have penetrative intercourse, then once I have a kid, and I'll make sure it's vaginal because that's what will help my pelvic floor, right? Not necessarily. So it shifts. So it's two different things. So number one, the causes of pain prior to pregnancy or childbirth can differ from pain after, right? Because oftentimes pain after, while there can be pelvic floor involvement, can involve hormonal changes that can shift the vaginal tissue, that can shift how our bladders function. And so I always say my youngest patient is somewhere around 15 and my oldest patient somewhere like 82. It is throughout the spectrum. Causes vary on each end, but I would say it doesn't shift towards more one end or the other end. I think I have a lot more younger patients than I do anything else.
And I like that we're mentioning that because I think there is this idea, that you're in one camp or the other camp.
Right.
And this really, to me, is a fluid concept of if you are a woman, and you're going to experience some of these things. It's just part of the nature of anatomy, you know?
Exactly. I mean, the data suggests somewhere around 25%, but that's actually because it's so stigmatized. I mean, we actually think the percentage of women who will suffer from some sort of pelvic pain or pelvic floor disorder is more like 55 to 60%, which is high.
Wow, that's a huge difference in reported versus what we have now seen
Yeah.
in the workplace. Wow, that's amazing. Um, I want to talk about too how you talk about, the proper evaluation of pelvic floor versus not. The difference in because I've seen that where some people say, "Oh no, they checked out my pelvic floor, it's fine." I'm like, but who checked that out?
Yeah.
What type of person checked that out? What did that checking out look like? Describe to me that visit.
Yeah.
I think
So
there's a big disconnect there, Dr. Bahlani. So tell us about
there is a big disconnect there. And I often teach other physicians this. So I think it's really important. So number one, the exam has to be comprehensive. So when you're doing a pelvic floor evaluation, you're not just evaluating the pelvic floor, you're evaluating vaginal tissue with a Q-tip, something that's known as a Q-tip test, where it's actually pain mapping. You're taking a Q-tip around both the labia, the area of the vestibule, which is from the labia, into the introitus of the vagina. You're taking a feel of the vestibule, and then you're actually taking a feel of the vaginal tissue.
that.
Um, it starts with the Q-tip test if there's any pain or discomfort there, if there's anything that you can see visually that is shifted either under the microscope or anything dermatologic, things like lichen sclerosis, lichen planus, plasma cell vulvitis. We're looking for all of these different things. Then we're actually taking a finger and we're doing what we call an internal or bimanual exam.
Hmm.
You're taking a feel of the entire levator complex of the pelvic floor. So, just to be clear of what that means, these are muscles that control the bladder. So things like the pubococcygeus that control the colon, like we're just talking about constipation, the puborectalis, things that control the vaginal opening, the ischiocavernosus, bulbospongiosis, transverse perineum. So you're taking a feel of all of these different muscles. Now, there is a difference when you're examining the pelvic floor of something that's called a tender point or a trigger point. And it's important to understand this difference because phenotypically you're going to treat patients differently. You're going to give them different modalities to treat these two subsets of patients. So what that means is that when you do a digital exam, if you feel the pelvic floor and you say, you know what, I feel like a little knot. I always tell patients, think about like touching the tip of your nose, okay? So it feels a little bit harder than the rest of your face, okay? So you touch the tip of your nose and that muscle, whoop, spasms right back to you. Whoa, you'll feel it immediately. That is the definition of a trigger point, okay? A trigger point is a band or top band of muscle that has inflammatory cytokines that causes spasming reactions that are involuntary, that you can't control. That's why the whine, the breathing, that's
Yeah,
why that's
not going to work.
it's like
Yeah.
because you can't control it.
Hmm.
So that's a trigger point. That's one thing that you're looking for. Then the other thing that you're looking for is something that's called a tender point. So maybe you push on this area, it feels almost like a guitar string, like a band, okay?
Okay.
It's not triggering back at you, but man, is that harder tissue? This pelvic floor should, a term that I use, should feel supple. It should feel soft. It should feel healthy. It's like blood pressure. It has the ability to contract, but it has the ability to release. So it's not just in this banded, contracted
Hmm.
state. And
Okay.
that's what you're feeling for as well.
Hmm.
And then you're feeling for the bladder. Is it boggy? Is it feeling lower down? Is it higher up? But this is a full comprehensive pelvic floor exam because you want to make sure that there's nothing that you're missing. Because believe it or not, bladder-based symptoms can be coming from the pelvic floor. So some people who are like, I have frequency, urgency, I feel like I'm not completely emptying. 80% of the time, that's coming from their pelvic floor and not their bladder.
80%. Wow, that is a really big number. I was not aware of that. Okay. That's huge.
So 80% of patients that come into my office, and this is in the data, saying that they have interstitial cystitis, which is a disease of the bladder, in
Mhm.
fact, have pelvic floor dysfunction that's been misdiagnosed.
That's so important for people to know. Absolutely. Wow. I'm kind of floored by that idea that that is such a high number. And how many women suffer from this, you know?
And boom, and men can suffer from it as well. We talk about women here, but like, it is, I say that in one of my tweets where I say, if you don't have pelvic floor dysfunction, you make me nervous. But it's true because like that's how prevalent this is really in society.
And I wish more people talked about it, but maybe with this kind of conversation today, people look at it a little bit differently, I hope, and
Yeah.
see these vital signs and these concepts. Like you talk about, pain shouldn't have to be severe to be believed. And I think that's important because it's the idea of maybe it just hurts a little. Like it's not that bad. Like it hurts a minute, but then kind of I get into it and it's okay. Or I lose myself in it. And so then I'm kind of past it. I would hope that people could listen today and recognize that if you experience any kind of pain at all, you need to get that evaluated, period.
I love that. And I absolutely agree. And it's also this concept where so many people will come into my office and, they're put together, they look great. And so because they're not writhing around screaming or like unable to take care of themselves, their pain is not believed. And that is just the most mind-boggling part of this. Like,
Yeah.
how are we're expecting people to, not be able to tolerate anything in order to say, okay, now this warrants care, like,
Right.
come on.
Exactly. I love that. I really like hearing about that. So, are there any other misconceptions that we really need to address, especially for people who are hearing this for the first time and thinking, I had no idea I need to be checking out my pelvic floor. I had no idea about any of this. Is there any other misconception that we feel like we should address to kind of, help people that are really, this is new information to them?
Yeah. Um, yeah, I think there's a couple of misconceptions. One is that it's a women's only problem. No, it could occur in women or men.
Mhm.
Um, Two is that with pelvic floor dysfunction, it's like a one cause thing. So I think a lot of people are looking for a quick fix or like having a cold, like here's a medication and now you're better.
Mhm.
Oftentimes with pelvic floor dysfunction, this is something that can come and go. It's something that can kind of be present and not manifest itself in certain ways. So what I mean by that, I'll give you an example. When I was learning how to do this, I was training with a physical therapist because one of the people I was training with was like, if you're going to prescribe physical therapy, you should know what they're doing. So I went to the physical therapist, but I went with like a wand and an algometer, which is a pressure sensor. Cause I was like, okay, I want to, like my nerd self, I want to know what's happening. So they put the wand into my pelvic floor. She's like, Dr. Bahlani, you have pelvic floor dysfunction. And I was like, what? No, I'm completely asymptomatic. I don't have any pain. I don't have any discomfort, no urological symptoms. Your pressures are high. So in theory, right, the high pressure is a banded knot. So in theory, right, you have pelvic floor. I said, no, okay. After I had kids, I started to notice some symptoms creep up. And obviously, I was able to target it with having the tools that I have. But the point is that it can lay latent. Do you know what I mean? So some
Yes.
people want to believe that something caused this, whether it was an infection, a surgery, a bad sexual encounter.
Mhm.
Um, and oftentimes, my point is that there are other aspects to it and it's there, but it takes a little bit of manifesting with other things happening at once to kind of show itself.
And what age do you think, knowing that it can be latent, knowing it doesn't have to have something that propels you to get help immediately, and what age do you think that maybe if we're speaking about women right now, all women should actually go have their pelvic floor evaluated? At what age do you think that should be?
I don't think there's a specific age. I think for everyone, everything's different. Number one, I think if you're symptomatic at all, any issues, placing a tampon, urinating, sex, you must get your pelvic floor evaluated because none of that should be normalized and okay.
Mhm.
I think that for women who decide that they want to have children, having a pelvic floor evaluation by a specialist prior to childbirth, if that's something that's important to you, it's a good idea. Only because if anything was to shift after that, then I always tell my patients I have a baseline now. I kind of know what your
Yes,
baseline is, and then I can, should you have symptoms later, I know what I'm dealing with here.
it makes a lot of sense.
So that would be my recommendation. But again, like, for some people that might be earlier on, especially if they're symptomatic.
And what about for women that hit perimenopause or menopause and start noticing maybe other body changes? Maybe they haven't experienced, dryness. Maybe they haven't experienced pain, but maybe they're already experiencing hot flashes or they're experiencing, other changes in their body. And they have that general feeling of this feels off, this feels different.
Absolutely. They should be getting that. And perimenopause is so interesting, because it's a clinical diagnosis and it's something that that clinicians used to almost be like, well, if you're not in full menopause, then we're just waiting for you to get. That's not true, right? Because now we do certain hormone replacements for perimenopausal women.
Mhm.
And it's really important for their sex lives and so I think it's so interesting how medicine shifts in that way. But perimenopause is such an important time to be evaluated because it is the time where, again, like we're talking about, if we can prevent certain things from happening, you can live like we talk about now, your health span will match your lifespan. Like you will have a good quality of life throughout that time.
Exactly. And I think having this concept of we've got to take care of our physical health and our mental health, and then we have to understand that they are connected. And
Mm-hmm.
that to me is something I push so hard, even from a trauma informed standpoint, is that the body keeps the score of everything. And sometimes that pelvic floor pain or that pain with sex has so many other ties to other things that are deeper too. And it's just missed. It's just missed. And until we start believing and understanding that that works together and we are one being and it all has to be congruent, I don't think people will get to the place that they can get, to feel really healthy, completely.
And I love that. I read that book and I also like firmly believe that there, we have to understand that mind body connection, or at least we have to work with people that understand that mind body
Yes.
connection. Because I'm not a specialist in that area, but it is part and parcel of what I do. Because if we don't do that together, then you never get that full relief. Do you know what I mean? You're
Yes.
just kind of fragmenting things.
Yes. How often do you think that pelvic floor pain or pelvic floor dysfunction also equates to the necessity of hormone replacement? Are they mutually exclusive? Does it always have to happen together? Tell us a little bit about that.
So no. So there are people who can be in their 20s who have pelvic floor dysfunction.
Mhm.
Do I think when people hit perimenopause or postmenopause that the shift in hormones that can occur vaginally can create a slippery slope for hypertonicity of the pelvic floor? Sure. Again, we're talking about a chicken and egg situation here. What came first? Was their baseline somewhat a little bit more hypertonic and then this added fuel to the fire? And now we're in this whole cyclic picture? Maybe. But I think that's so individualized. And I think but there are people who can be in their 20s and be absolutely 100% fine. And in terms of their hormone levels, although they might be on OCPs, which can be related, can also cause a shift in hormone levels in the vagina, which can create issues with the pelvic floor.
Okay. And what about the concept of thinking about the loss of collagen that happens in aging? And that not necessarily tied to menopause, but just aging. As we age, men, women, both, we lose collagen in our body. It's just natural. We don't produce the same amount. This is what happens. That can absolutely affect, sex and tissues and all these things. I would like to talk about what that collagen part of it, because I think collagen is such a buzzword these days. And then a lot of people think that, oh, I can start using this collagen supplement. It's going to fix that. Okay, well, maybe not. So I would love to get your take on that and how that parlays into all this.
Well, collagen is very important to our vaginal health, to be quite frank. But and I'm not necessarily confident of the data in terms of like oral ingestion of collagen, but I will say that vaginally, we do use things like hyaluronic acid to increase collagen production. We do use things like topical estradiol and testosterone, which also increases collagen production. Because vaginally, when we're able to do that, we're able to normalize vaginal pH, which is really important for preventing recurrent UTIs, recurrent BV, and just maintaining a normal, healthy vaginal microbiome, which is stuff that we're learning a lot more about now. So I think collagen production for vaginal and women's health is super important. I'm a big proponent. I mean, I still have collagen in my coffee. I just don't know the data behind it and the actual vaginal health. But I actually am a huge proponent of utilizing things like hyaluronic acid,
Mhm.
topical hormones for vaginal health and collagen and maintaining collagen in the area.
Mhm. Because I feel like personally, I've recognized that when we use, and you specifically, you hit the nail on the head, the hyaluronic acid, that part of that to really think about how what we can be doing to supplement our body that affects us in so many ways. So, you're validating that belief for me right there that I've been pushing that for a lot of people. And for me to hear you say, yes, I mean, that is important for your vaginal health, because I think also gut health is important to your vaginal health.
Oh
If
my
we do not have
gosh.
a healthy gut, then that is our second brain, as one of my therapists has often said. And I like to quote her on that. The gut health is our second brain. If we have a very poor gut health, it is going to affect our overall wellness, which also translates to our vaginal health.
Absolutely. 100%. And that's why even when you look at things like pelvic floor dysfunction and vaginal health, so many patients have this concomitant diagnosis of IBS.
Mm-hmm.
There is what we call visceral convergence. The gut and the vagina, they talk. They're always
Yes.
communicating.
And if you're
And
eating sugar, if you have a diet that's so predominant in sugar, and you as a person are predisposed to have, that candida aspects or things like that, that your body can't metabolize that. Because I know some people don't have that big problem, but some people are very sensitive to that. And then that immediately can create this problem where you're having that repetitive vaginal pH issue, which can lead to BV or yeast infections or anything else. And it all is tied in what we eat. What we
exactly.
eat and how much do we take care of the whole body, like we're talking about. That holistic aspect is all connected. And we cannot be healthy in one way without being healthy in all the ways. Because I challenge someone that tells me, yeah, I work out all the time and I see a therapist once a week and I'm great. Okay, but are you? Because you do
Yeah.
everything else. I mean, do you go the next 5 steps? Because it doesn't just stop with those two things.
Yeah. I mean, there's absolutely, we are definitely the same philosophy. I agree.
I like hearing that from somebody trained at your expertise, because I don't have that training or that experience, but I've just seen it firsthand in the work I do with the clients I work with.
No, and they're lucky to have you. I mean, the hyaluronic acid stuff is stuff that's newer now, but even now we're starting to do injections of it. I mean, we're starting to really learn more. And while it's on the cusp of where a lot of people are, even just applying it, like I will often compound it for my patients. There's also brands that have it out in the store if people want to buy it, but
Yeah.
it is very important for building collagen to the area.
Right. I personally tried a vaginal suppository that is hyaluronic acid to see what that was like. It was recommended to me by somebody as well, and I've recommended to others, because it's just one thing that helps our body continue to stay where it needs to stay and not on the decline of aging.
Right.
To me, that doesn't even have anything to do with the sexual part of it. That has to do with, let's just keep our body in check of where it needs to be. And then
I
the plus to it is great. We're going to have great sex from it. Awesome.
That's exactly how I feel. I always tell patients, I'm like, we do all this stuff for our face. I mean, we buy $100 serums. We make sure that the skin on our face looks perfect. And yet we expect the skin, just like anywhere else in our body, in our vaginal or vestibular tissue to be healthy without taking care of it. We have to take care of it.
Okay, I love that you said that too, because I recently, a company contacted me about a cream that just helps with almost like what we would equate to lotion on our skin, just to continue to create a moisture barrier, because skin dries out. We get older. Again, less collagen, less, the friction of the clothes we wear, things like that. What are your thoughts on just even the outer tissues of paying attention to being able to make certain we're taking care of from the external part of that too?
Yeah, I think that there are, it's twofold. Okay. So number one, I think it's very important to keep the area healthy in the sense that like if you're feeling something, then yes, you should get evaluated and perhaps you should consider things like these newer things that are out there like hyaluronic acid. And the problem with different vaginal moisturizers though is that they can be sometimes irritative to the area and sometimes less is more. Do you know what I mean? Like so and the vagina truly and we both know, is a self-cleaning oven.
Yes.
So I am so kind of like
Well, we start worrying about pH. We start worrying about disrupting everything else for sure.
exactly.
But what I liked about it was that somebody was paying attention. Somebody was thinking, you know what? This is often just forgotten about. And then what
Yeah.
are we doing to make certain that all parts of our body are healthy? And from that aspect, I applaud it. Now, whether that specific thing is the right thing, I don't know. That's not my decision to make. I'm not in your field. But I like that there is an attention now to really recognizing there's a lot of things that we can be doing, and it doesn't have to be limited just to as we age. Oh, let's get maybe what do we need to tweak on our face? What do we need to do? It's actually our whole body, and I
Yeah.
like where you're going with that. I think that's so important for people to really shift their mindset. about
Yeah.
that from a whole body perspective. And you have such a holistic perspective that I love, that I feel like often is missed when we're talking about medical doctors. And I love that you have that. And I think your clients are really lucky to be able to have that with you as well. So I think that's wonderful.
Thank
Um,
you.
I think this has been so educational for people, and I love that we've touched on some things that maybe aren't often talked about. So I want
Yeah.
to be sure people buy your book, Dr. Sonia's Guide to Navigating Pelvic Pain, Result-Oriented Strategies for Better Quality of Life. We're going to have that linked in our show notes, of course. But often what we do also when we're on this podcast is a prior guest leaves a question for the current guest, and we continue that on. It's an interesting kind of thing we like to do to forward motion all of our
Yeah.
guests and how it's all connected, all these topics we discuss. So the question left for you was, what is your favorite compliment to receive and why?
Oof. I think my favorite compliment I've ever received is, I like how you took that compliment. So what I mean by that is that often as women, when we're given a compliment, we're like, oh, no, 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 oh, no. Or like we compliment right back. And sometimes I think just a simple thank you and accepting what someone else is telling you is just so powerful. And I think that for me, that was probably one of the best compliments I got.
Well, that has a lot of validity to it because, not being able to accept a compliment runs a lot deeper than
Yeah.
what it seems. So, from a psychoeducation point of it, absolutely being able to say, yeah, I appreciate that. Thank you. I agree with you. I like your answer. So what do you want to leave as the question for the future guest?
So now this is one that I used to get at when I used to do like interviews of other like when I used to interview residents.
Mhm.
And do you remember what AOL was? Like AOL AIM?
Yes, I'm old enough to have had that. Yes, yes, got
And
it.
so I don't know if all your guests are old enough to like have
Well, it
that,
was
but
an old, let's say it was an old dial-up platform for internet access, and AIM was what it was. It was a direct messaging function
yeah.
back then.
And back then you had screen names. And so like your screen name was supposed to be like your identity on that platform. So one of the funniest questions I think I've ever gotten was, what was your AOL screen name and why? And I think it just spoke so much to like who I was as a person, and I thought that was funny.
Hey, and so I like that. And in case I have a guest who did not know that, I just like the screen name concept in general. Like, how do you label yourself? I love where you're going with that. That's going to be fun to see what the next guest says about it. So we will circle back with you, Dr. Bahlani, and tell you so you know what that answer was. Again, it was a pleasure having you today, and I really appreciate you educating us all about pelvic pain and pelvic floor and your specialties and your work. It was really great.
Thank you so much for having me. This was a lot of fun, and I felt like this was a great conversation.
Awesome. Well, we will stay in touch.
Yes, definitely.